Yeah, very good evening, all of you. This is Dr. Sachin. I'm the mentor at Study Ultrasound, and today we'll be talking about the ultrasound examination of the appendix. We'll be talking appearances of the appendix. Before going into the details of ultrasound examination appearance of the appendix, we'll be just we'll just talk in brief about the acute appendicitis. As we know that it is one of the most common cause of acute pain in right iliac fossa region, and we always need to do clinical radiological correlation, because while doing examination of appendix to rule out appendicitis, we should always know the clinical background in detail. So most of the patients of acute appendicitis, they present with acute pain in periumbilical region that shifts to the right iliac fossa region, that is right lower quadrant of the abdomen. The symptoms may be a bit variable depending upon the position of the appendix, and if the appendix is located retrocecal in position, the patient may present with complaints of loose motions and tenesmus, that is feeling of evacuating the bowel frequently. And if the appendix is located somewhat in the subhepatic in region, the pain may be located in right hypochondriac region as well. There will be, on clinical examination, there will be tenderness in the right iliac fossa region, or maybe in right hypochondriac region, depending upon the position of the appendix. And of course, on blood examination, there will be leukocytosis. So before going into details of the ultrasound appearance of abnormal appendix, we'll talk about the normal appearance of the appendix on ultrasound examination. So as we know that appendix is a blind ending tubular structure located at the tip of the cecum, and these are the variable position of the appendix. As we know that the position, it can be pre-ileal or post-ileal position, can be subcecal, can be pelvic, can be retrocecal or paracecal. The retrocecal appendix can even reach up to the subhepatic region. So there are variable appearance of the location of the appendix, and we should be aware about this while looking for the appendicitis. So on ultrasound examination, we need to examine the cecum and IC junction, and we need to localize the appendix properly. And we'll be seeing the appendix as a blind ending tubular structure, which is sausage-like. On ultrasound, it will not have any peristalsis. So it will not show any peristalsis because the muscle layer is absent in the appendix. Then it will be arising from the base of the appendix, and it will have a gut signature. We'll see in the ultrasound picture later on. A normal caliber of the appendix is below 6 mm on ultrasound examination. So this is the normal appearance of an appendix on ultrasound examination. We can see a blind ending sausage-like tubular structure, which is of caliber in this particular image of 3.2 to 5 mm. And for examination of the appendix, we should be clear that apart from high resolution curvilinear probe, we should always use the linear probe. We should always use the high resolution linear probe for examination of the appendicular wall, its vascularity, its compressibility, and entire appendix should be properly examined. So it is found that the visualization of appendix on ultrasound is a bit variable, and that's why it is operator dependent procedure. There is a lot of operator dependency in visualization of the appendix. But normally it is found that if the appendix is normal, it can be visualized in up to 20 to 30% of the patients if it is normal. And if it is inflamed, it will be visualized in almost 90% of the patient. So that makes it easier if the appendix is inflamed, and you will be easily able to visualize the appendix most of the times. If the appendix is not inflamed and it is not visualized, in many cases it is definitely normal. But of course, you have to do further imaging if the clinical condition is suggestive of acute appendicitis. So for how to trace the appendix on ultrasound, let's see these images. We can see the cecum and appendix arising from its tip or from its base, and we can see that it's a tubular structure with gut signature. We can see the serosal surface, we can see the mucosal surface, and we can see the submucosa as well. Just play the video for me, Noreen. So for examination of our appendix, we have to look for the cecum. We need to trace the cecum in its from up to the IC junction, and then we need to localize the appendix, because the tip of the appendix has a variable position. So as we can see in this video, the appendix is seen as a tubular structure with the gut signature. It will be blind ending. Even if you trace it, when you trace it in its entire course, it will be blind ending structure. And the various layers of gut can be seen as submucosa, mucosa, and the serosal surface. So the normal appendix has a caliber of less than 6 mm, but there is some variation. This is a particular study published in the Radiology Journal in 2014. It is found that if the appendix is normal in caliber, especially if it is less than 5.7 mm, the patient will not have appendicitis. So there are no cases in which the appendix is found to be less than 5.7 mm caliber in this particular study, at least, that they're having appendicitis. So the patient, if the caliber of the appendix is less than 5.7 mm, you can surely rule out appendicitis. At the same time, if the appendicular caliber was found to be of 9.8 mm and above, it was found that almost all of the patients which have a caliber of this appendix of this caliber has acute appendicitis. So the gray area lies over here. If the appendicular caliber is between somewhat 6 mm up to 9.8 mm, there is bit overlap. Some of the patient may have appendicitis and some of the patient may not have appendicitis. So if the appendicular caliber is more than 9.8 mm, it is very definitely the appendix is inflamed. Either it is because of appendicitis or it's because of some other neoplastic etiology. It can happen rarely. So this caliber is sure shot, but definitely if appendix is above the 6 mm in caliber, we need to consider appendicitis, though there is some overlap of normal cases. Let's talk about the ultrasonographic appearance of acute appendicitis. There can be bit variable appearance again, so we need to look for these features. The diameter of more than 6 mm. Again, secondly, even if the diameter is of 6 mm and above, it should be incompressible. The inflamed appendix, suppose you are in the gray area, suppose the diameter is between less than 9.8, suppose it is 7 mm, and you are again in doubt whether this appendicitis or not. So then we need to look for its inflammatory changes. So inflamed appendix will be non-compressible. If you press the probe a bit harder, it will have a lumen which is non-compressible. Then apart from that, the periappendiceal fat inflammation will be there. The mesoappendix may be inflamed. There will be fluid collection along the tip of the appendix and periappendiceal planes. And the appendicular wall, which should be less than 3 mm, it is usually 2 mm in thickness, but in acute appendicitis, the appendicular wall will be of approximately 3 mm and above. Then there will be fluid collection in the periappendiceal plane. We can see appendicolith. Almost up to 35% of the cases, we can see a echogenic focus within the lumen of the appendix. That is called as appendicolith, which is most of the common cause of appendicitis. Because if the appendicle is stuck inside the appendix, it causes inflammation of the distal appendix. And definitely the maximum probe tenderness. If you press the probe in right iliac fossa regions over the cecum, and if you press the probe over the appendix, you will see that the maximum tenderness is over the appendix. So these are the features, ultrasonographic features, that will suggest that appendix is acutely inflamed. As the image is depicted, it is that you can see a compressible lumen will be a normal appendix and inflamed appendix will have an incompressible lumen. Again, in the lumen, you can see variable appearance. At times, you can see pus cells with the fluid level, the pus fluid level. It can be the luminal contents can be echogenic, filled entirely with the purulent collection. At times, and most of the times, inflamed appendix will not show a gas in the lumen. So the appendix, gas within the appendicular lumen is suggestive that the appendix is less likely to be evident, but it can be again a variable feature. Another important feature of acute appendicitis is the wall hyperemia. So the inflamed appendix will show inflamed walls, which will show increased wall vascularity. As the ultrasound image over here is depicted, you can see a normal appendix which has a compressible lumen is not showing any vascularity, and this is a power Doppler mode, and you can see a significant increased vascularity along the walls of the inflamed appendix which has an incompressible lumen. These are the variable appearance of acute uncomplicated appendicitis. What do we mean by complicated appendicitis and uncomplicated? So it's an acute appendicitis, which is just appendix is inflamed. There are no another complications of acute appendicitis. We can categorize them as uncomplicated acute appendicitis. So complicated appendicitis will have another complications happening around the inflamed appendix. That can be pus collection, that can be abscess collection, there can be a perforation of the appendix, there can be appendicular lump formation, there can be bowel obstruction, etc., etc. So, and non-complicated appendicitis will have rounded lumen of the appendix. It can be luminal contents can show pus cell, or that is purulent discharge, that will show fluid level or pus fluid level. You can see appendicolith inside the lumen. Over here we can see an appendicolith in one of the image, a bright echogenic structure with distal acoustic shadowing. And appendix distal to the appendicolith is significantly enlarged in size. See the caliber, see the amount, the luminal contents, they are hypoechoic, suggestive of pus cells. The mesoappendix, the mesentery of the appendix again can be inflamed, and you can see significant thickening of the echogenic fat within the mesentery of the appendix. As the appendix is inflamed, the mesoappendix is also inflamed. So that is what is called as focal appendicitis in this particular image. We can see at times the appendix may be inflamed in its distal part. Some may be in the tip, around the tip of the appendix, and the base of appendix may be normal. So that is the reason we should always examine the appendix from the base up to the tip. It may be a bit difficult to localize the entire appendix depending upon the inflammation in the right iliac fossa region, pericecal region, but definitely you have to do it. So once in this particular image, you can see the base of the appendix is normal in caliber, and the tip of the appendix is significantly inflamed. We can see the rounded caliber, incompressible lumen, and the pus cell or maybe fluid level within the inflammatory cells within the lumen. And wall hyperemia is seen at the base of the appendix as well as the tip of the appendix. So a normal caliber at the base doesn't rule out the normal appendix. You have to trace the entire appendix. That is what is called as focal appendicitis. So let's talk about some complications of the acute appendicitis or complicated appendicitis. So as for the complication occur, apart from if there is some perforation of the appendix, at times you can visualize the perforation, site of the perforation. In this particular image, you can see a hypoechoic filling defect within the serosal surface as well as the mucosal surface, which is suggestive of perforation, the site of perforation of the appendix. So once the inflamed appendix perforates, it causes significant inflammation around the periappendiceal plane. There will be fluid collection and pus abscess collection formation. The entire mesentery adjacent at the bowel loops adjacent to the appendix, they will become adherent to each other, and they will subsequently form a mass. Even inflamed appendix itself without perforation can cause appendicular mass, which is subsequent complication of the acute appendicitis. If the cecum and the adjacent mesentery and the appendix, they get inflamed and get adherent to each other, they subsequently form a big mass. So most of the times, but actually most of the times, the complication is because of the appendicular perforation or inflammation and secondary infection of the periappendiceal soft tissues. So in this particular image, we can see the appendix is inflamed, showing significant volvulus hyperemia, and apart from that, there is hypoechoic fluid collection posterior to the appendix, which is showing debris inside. Fluid debris level can be seen, and the adjacent mesentery and the bowel loops are adherent to each other. That is, the appendix, the mesentery, and the bowel loop and the pus collection, the entire thing is adherent to each other, and they are forming a big mass. That is what is called as appendicular mass. And this is periappendiceal abscess formation. At times, the appendicular mass can be very complicated, and it will be very difficult to visualize the appendix many a times. Even this particular image, we can see a complicated appendix pus formation around the periappendiceal plane, and the appendix is significantly compressed. Even if at times it is appearing as a normal caliber, isn't it? But if you put color Doppler box over here, you will see the hyperemia, and this particular pus collection around the periappendiceal plane is because of the secondary infection and perforation of the appendix. So, in case of complicated appendix, many a times it may be difficult to localize the appendix itself, and even whether to decide whether this is acute appendicitis or there is some other, it may be some perforation of bowel has occurred over there, and that is causing inflammation. Because if you are not seeing the appendix, how will you decide this complication is because of it? So when we need to go beyond ultrasound examination. So if you are not visualizing the appendix clearly on ultrasound examination, and you are seeing significant inflammation in the pericecal and IC junction region, we are seeing some pus collection and some lump mass of the adherent bowel loops and abscess and small and large bowel and mesentery, and the appendix is not visualized, then of course the differential diagnosis in this particular case will be acute appendicitis, perforated one, as we can see some pus collection. But as we are not seeing the appendix, so we need to go for further imaging. And on CT, we can see the appendix is inflamed over here. We can see the inflamed appendix, and there is pus collection along the periappendiceal planes. So further imaging is definitely required if you are in doubt. If you are seeing the appendix and it is inflamed, the diagnosis is clear-cut. You are seeing the appendix and there is some pus collection and other complications there, then there is a complicated appendicitis. But if you are seeing some only inflammatory changes in right iliac fossa region and we are not able to visualize, then we have to go for cross imaging. And even if you are not seeing anything that is suggestive of appendicitis, and you are on clinical background, as per the clinical background, this is very highly suspicious of the appendicitis, and you are not able to visualize the appendix, no other inflammation in the pericecal region, still you have to go for the further imaging, that is CT examination, contrast enhanced CT examination. At times, the inflammation in the right lower quadrant may not be because of appendicitis, and the reason may be something else. Other reasons are the IC junction tuberculosis or inflammatory bowel disease affecting the cecum and the IC junction or terminal ileum. So, inflammatory bowel disease affecting the cecum and IC junction, or infective bowel disease like tuberculosis, IC junction tuberculosis, can present as acute pain in right iliac fossa region. Though the pain may be chronic, acute on chronic, but on ultrasound examination you will be seeing inflamed cecum and IC junction, and at times you may not visualize appendix. So even if you are visualizing appendix, which in this particular case you are visualizing the appendix which is of normal caliber, but there is significant inflammation of the cecum and the terminal ileum. So we have to go for further imaging to rule out whether this is because of acute appendicitis or some other reason. And in this particular case, it was because of inflammatory bowel disease. Even on CT, the appendix is of normal caliber, no periappendiceal inflammation is there, but the cecum and the terminal ileum are significantly inflamed, showing increased wall thickness and post-contrast wall enhancement. And last but not the least, definitely the appendicular neoplasm has always to be considered for when you are seeing some inflammation in the right iliac fossa region. Now, if you are able to visualize an appendix and a mass in relation to the appendix, the diagnosis is clear-cut. But if you are seeing some irregular wall thickening in the right left fossa region involving the cecum and IC junction, and there is too much of chaos, you are not able to visualize the appendix, then again you have to go for the cross-sectional imaging, that is CT abdomen. In this particular case, they found that there was a mass in relation to the appendix which was not visualized. There was irregular thickening of some bowel loop in the right left fossa region. There was too much inflammation, and at the same time there were some masses, heterogeneous masses involving the hepatic parenchyma. So now they need to rule out the neoplastic etiology, and in this particular case it was because of the malignancy of appendix, which has got metastatized to the liver parenchyma. Okay, so though it is very rare, but the neoplastic etiology involvement of the appendix is a rare thing that always needs to be considered while doing ultrasound examination for acute appendicitis and for right left fossa pain. So that's all about the normal appearance of the appendix as well as the abnormal appearances. Thank you for attending this session, and welcome to Study Medic. If you need to know further details about the various classes of Study Medic Ultrasound, you are always welcome. Thank you.